Thank you. Thank you. This is a sort of a dry topic because it's on dry macular degeneration. You can't do anything about what I'm going to tell you. But I think it's something that's going to come, and I'd like to acknowledge some of the slides that I've used from Robin Guymer, who's big in dry macular degeneration. So, you know, we sort of, I wouldn't say conquered, but we certainly made a dent into wet macular degeneration, but macular degeneration itself remains an important cause of blindness in Australia and many countries. The Fight Retinal Blindness Project is a sort of a review registry of injections, and it shows that 40% of those receiving injections at 7 years still have driving vision, which is 6/12 or better. It also showed that earlier treatment produced better results, and similar studies in other countries like Denmark showed that in the anti-VEGF era, our blindness has gone down. But what about the other 15% of people who develop late macular degeneration and get into the dry category? This is really the new frontier because we haven't done anything for them as yet. And very often you look at a dry patch and you send the patient off. And we know that geographic atrophy is a late manifestation of dry macular degeneration. And in the years to come, this is going to be the big problem that we're going to be managing. Patients will often ask, you know, is it getting worse? Is it getting better? And you just look at it and you say, to me, it looks the same. But the patient says, no, I don't feel so good. So really now I'm getting a little bit into the nitty-gritties of looking at high-definition OCTs to explain to you how you can actually look at an OCT of dry macular degeneration, which you possibly wouldn't bother doing, to find out whether things are going better or worse. The other modalities that one can use, visual acuity, for example, in the functional measures, we could look at autofluorescence and so on. So unfortunately, visual acuity and functional measures are not very good. There are a number of them because visual acuity, for example, doesn't really estimate how bad the disease is. Very often you could have a central viewing area or a central sparing of the fovea and you can get pretty good vision but very bad visual symptoms and performance. So one could have good visual acuity even though the GA is getting worse. So obviously visual acuity is not a good idea. And also in the short term, all these various functional parameters are not sensitive to change. What about autofluorescence? Now, geographic atrophy is a color fundus photography definition. It's not any other this thing. But if you do autofluorescence, you can actually pick out areas and also you can define the extent of the geographic atrophy. As you would see here, they all look the same. They've got drusen, you've got hypopigmented patches, but the true patch is only this one of geographic atrophy. So autofluorescence tells you which of these funny-looking white things are geographic atrophy. Also, the junction between geographic atrophy and the normal retina is where photoreceptor cell death is taking place, and that you can see quite clearly on the OCT, as you can see in these two pictures. So you've got the area of geographic atrophy here, where there's thinning, and I'll come to that, but you know, where the arrows are is really where the photoreceptors are dying. We also need to know, and this is more a research thing, that geographic atrophy is not geographic atrophy. There's not only just one variant of geographic atrophy. Geographic atrophy has been now classified again to try and look at treatments into different forms, and we find that the trickling form of geographic atrophy is the one that progresses the fastest. So if you really like to study geographic atrophy, try and classify it, and then you can tell the patient how bad it's going to be. But you know, this normally goes at about 2.6 to between 1.7 and 2.6 square millimeters per year in various studies. So far in routine practice, we just use autofluorescence, and if you see and look at the autofluorescence, you might be able to hazard a guess and say, well, this is a progressive or this is stable disease. But also to remember that, you know, the geographic atrophy doesn't keep growing forever. As it gets bigger, its growth slows down. And that's something that you've seen over years. But now let's try and predict which geographic atrophy is going to become worse. And you know, over years, things start off as drusen with pigment change, and then ultimately you develop geographic atrophy. So if you look at all these, they all look the same, and you want to know which one of these is going to get worse faster than the others. Dr. Wu from the University of Melbourne has been studying serially geographic atrophy over the years, and you can see the natural history of geographic atrophy is really that the drusen ultimately disappear and geographic atrophy develops. So if you look at drusen and you keep monitoring drusen, these drusen will not stay the same forever. They will slowly regress, and very often they leave behind a patch of geographic atrophy. But the areas that we need to look at on the spectral domain OCT are the 4 layers which are close to the choroid, which is the retinal pigment epithelium, here, the outer segments, the ellipsoid zone, and the external limiting membrane. And now if you keep a watch on these, we'll go through what happens. Now let's look at some intermediate drusen and see what happens to them with time. So what we see here is now they have defined a term called nascent geographic atrophy, which means what happens before geographic atrophy occurs. And you can see that the drusen here, this is the area of geographic atrophy. You do the OCT and something is happening. These layers are changing. So what we see is there's a subsidence of the outer plexiform and the inner nuclear layer. And you can see that over here there's increased transmission. And then these changes here, like you've got a hyporeflective wedge-shaped band there. So this is termed nascent or pre-geographic atrophy. Now this is one thing, but what happens even earlier than this? We find that there are hyper-reflective transmission areas here associated with a transmission defect. So when drusen start moving towards geographic atrophy, you first get hyperreflective foci, then you start getting the nascent geographic atrophy changes. So hyperreflective foci are a risk factor for progression towards geographic atrophy. The other thing that's been seen are reflective substructures in the drusen. So drusen are not drusen. You can see that there are some funny things going on in the drusen. For example, you can have an area of low reflectivity here, high reflectivity, conical structures, and also a mixed. And we find that the conical ones are often associated with the development of geographic atrophy, but not CNVM. The other thing is the presence of reticular pseudodrusen. Now, what are these? These are subretinal deposits. Drusen are sub-RPE deposits. And so the presence of pseudoreticular drusen or reticular pseudodrusen, as you can see here, you can see that these are subretinal and not sub-RPE. And these are often associated with the development of dry AMD and not CNV. So in summary, there are some things that you can look at on an OCT and try and figure out for yourself whether this looks like a high chance of progression for this dry macular degeneration. And, you know, so just to say that all geographic atrophy is not simply geographic atrophy. There are geographic atrophies that will progress, and there are others that will remain relatively stable. Now, why is there no, no progress in the management of dry AMD? That's because we don't really have a very good animal model. You can induce a CNV quite easily, but dry AMD, there is no animal which has got this problem. It's only stuck with us humans. And also, the issue is that it takes so long to develop, and it's so variable that you can't really make out what's working and what's not working. Based on what I've told you about the changes that one can pick up before GA develops, when drusen are there, the nanosecond laser, which is a laser that acts so quickly that it doesn't create any thermal damage as in the upper, this thing. All it does is, it's so short that it doesn't create a burn, but it certainly increases the number of MMPs, which are what's needed to remove this waste material that drusen are all about. So Robin Guymer and her colleagues in Melbourne have been studying this for a long time, and you can see some of the results. They're fascinating, because if you see here, I mean, this is the control eye, and this is the eye that was treated. And you can see the drusen here, 2 RT lasers been applied, and 12 months later, the drusen have disappeared. But you say, but that's the natural history of drusen. They disappear and they produce geographic atrophy, and that's the reason why we are waiting now for the results of this study, which will come out. The last patient is going to be seen in April. Now, microperimetry also shows that there's an improvement. So the drusen become less, you can see from here to here. The function improves, so there certainly seems to be some effect of this. So we're looking forward to the results of the LEAD study, because it must satisfy the one thing of any drug or any treatment is do no harm. But it certainly has some promise when we're looking at what the future of treatment for dry AMD is going to be. The Pillai study, with APL20, is so far the only one which has shown a reduction in size or in growth of the geographic atrophy. So it's a dry topic, but it certainly needs to be understood if you're going to be looking at the other side of macular degeneration. Once you've conquered CNVMs, you really need to understand dry macular degeneration. You need to understand what you're seeing on a fundus autofluorescence. You need to understand what you're seeing on an OCT so that you'll be able to monitor what's going on. And even if you use something, you'd be able to see whether your treatment is working or not. Thank you.